Jai Hind everybody. In continuation with the educational videos on implants and other periodontal surgeries of PERIO Subharti, today's video would be a continuation of our earlier video. So if you remember, in the earlier video we had demonstrated various types of implant kits, physiodispenser, significance, etc. Now in today's video we'll be giving you a hands-on demonstration of implant placement on artificial mandible. So in the last video, if you remember right, we had covered up implant kits of 3 different countries: Ostem from Korea, Alpha Bio from Israel, and iFix from India. Today's video would be focusing basically on the Indian kit, the Made in India kit iFix. So we'll be demonstrating this. We'll be demonstrating the various parameters of Physiodispenser that we are supposed to keep in mind while drilling. And then finally, some basic tips and tricks of how the angulation of the implant is supposed to be managed whenever we are doing the osteotomy preparation. So without any further delay, let us start with the demonstration. So starting with the demonstration. So suppose a patient has come to us with a missing tooth. What's the first thing which we have to evaluate? It is known as retrospective treatment planning. So what is the meaning of retrospective treatment planning? Implantology is prosthetic driven surgical treatment modality. So the first thing which we have to evaluate is that whether space is present for placement of a tooth or not. That is the first thing which is important. Implant patient hasn't come for implant, patient has come for tooth replacement. So two things you have to evaluate. In 2 dimensions you are supposed to see whether mesiodistal ample distance is there for placement of a tooth, and then you are supposed to ask the patient to occlude, and you are supposed to see whether in the apicocoronal direction ample distance is there for placement of a tooth. So this is the prosthetic treatment planning with regard to a single tooth replacement by an implant. Now once you have gathered this thing that ample space is available for tooth placement, the next thing is of course evaluating bone. So how do you evaluate bone? The first thing is you see whether ample height is present or not from the next vital structure. In this case it would be the mandibular canal. So you advise an OPG, you take an RVG, and you get a rough estimate that ample distance is existing from this crest of the bone inside this soft tissue till the mandibular canal. But that has given you only a 2-dimensional image. You have gotten to know only the rough estimate of the length. The width is still remaining. So width, how will you get to know? Through CBCT. So CBCT will tell you that what is the buccolingual dimension of bone available with which you can place the implant. Now based on these parameters and based on the tooth which you are replacing, you will be choosing the size of the implant that you will be placing. So size basically means the diameter and the length of the implant. So accordingly, based on available bone and the tooth which you are replacing, we try to place the widest and the longest possible implant. Whenever we have to make a choice between width and length, a common misconception is going for the longer implant. No, that is wrong. Please understand, ultimately the survival of your implant is dependent on something known as BIC, bone implant contact. So BIC, if it is more, the longevity of the implant is more. BIC is less, the longevity or the life of your implant is less. So please understand that 3 millimeter increase in the length of the implant increases the BIC by only 10%. On the other hand, just 1 millimeter increase in the diameter of the implant increases the BIC by 20 to 30%, depending on whether it is an active implant or a passive implant. Passive implant means the threads are closer together. The BIC would be more in the case of a passive implant. An active implant means the threads are wider apart, the BIC would be lesser. So given a choice, which one will you choose? You will choose the widest possible implant if possible. Now, suppose I want to place an implant in this area, right? So what I need to do is, based on CBCT, I have to choose a dimension of an implant. Now once I have chosen the dimension of the implant should be such that after placement of the implant, ultimately minimum 1 mm of bone should be remaining on the buccal side and 1 mm should be remaining on the lingual side. At least that much of cortical bone thickness should be remaining. The next is 2. We say rule of 1, 2, 3. 2 basically means that ideally after placement of the implant in the center, roughly 2 millimeter distance should be there between the outer border of the implant and the adjacent tooth. 2 millimeter on mesial side, 2 millimeter on distal side. This 2 millimeter is actually based on the concept of biologic width that I'll cover up in a separate detailed lecture. And finally, 3 means that minimum 3 millimeter of distance has to be available in the apicocoronal direction, because less than 3 millimeter you won't be able to place a crown. So this is the 1, 2, 3 rule of implant placement. 1 mm buccal lingual, 2 mm adjacent side mesial and distal, and 3 mm in the apicocoronal direction. So now I have decided that this patient I would be able to place an implant. So what's the next step then? Let us say this is the area in which I want to place an implant, right? So once the flap has been reflected, always and always it is always better that with the vernier caliper we again take the dimension of the buccolingual width. So suppose the buccolingual width is 6 mm, which is the maximum diameter of implant which you can place, it would be 4 mm. 4 mm why? 1 mm on the buccal, 1 mm on the lingual. Suppose I want to know that how much is the distance of a 4 millimeter implant, at which point should I do the drilling? It would be 2 mm plus radius of the implant, because my drill would be going in the center of the implant. So how much it would be? 2 mm plus 2 mm, that is 4 mm. Meaning if I set this vernier caliper, we call it bone gauge also, and I mark a 4 millimeter point here, that would be the point in the center in which my drill should be hitting. So did you understand the concept? Why did I measure it as 4 millimeter? 2 millimeter from the outer border of the implant to the adjacent tooth, and 2 millimeter is the radius of the implant which we will be placing, right? So the next step is Physiodispenser. So as covered in the earlier video, this is the apparatus that we need to use, because ultimately the objective is atraumatic osteotomy preparation. Then only your implant will be surviving in the long term. So normally the two parameters which you are setting is RPM and torque. So RPM roughly 800 to it should be maximum 1200. On an average we take 1000 RPM. And torque, the rotating force should be 30 to 40. On an average we can take it as 35. Okay. Now this is artificial mandible. So naturally what will happen is much higher RPM, much higher torque would be required. So in this case what I will do is I will just set it at let's say 2000 RPM, and the torque I will set it to the maximum as 50 NCM. This I am setting only and only from a demonstration point of view. This is not what you will be doing in the patient as such. Is it fine? So let us now begin with the demonstration of the placement. So for demonstration of the placement, this is the Physiodispenser that we will be using, and these are the iFix implant kits that we will be demonstrating. So this was the earlier kit. This is the more advanced recent kit of iFix and made in India implant system designed by IIT Delhi. So this kit basically is of 2 chamber, in which the lower chamber has the depth gauge and the torque ratchet as such. Otherwise, more or less, other than the cortical drills, the remaining part is the same. So these broad parts, do you remember we had covered in the last video? The main component of an implant kit is what? Sequential drills. You need to gradually increase the diameter of the osteotomy. Okay. What is the next part? These are drill stoppers. Drill stoppers basically means you don't have to count how much of the drills are going inside. You can blindly put the drill stopper and you will be able to do it easily. Okay. Which were the other components? We used to have the ratchet or the extended mount, which used to be attached in the ratchet, and we used to have the hex driver. So hex driver again for placement of cover screw. And what else was there? We used to have the depth gauge and the most expensive component, torque ratchet. So detailed discussion of all these components we had taken in the first video. Here I will be only demonstrating. Okay, so let us start with the placement of the first drill which is required. So please understand, as I had covered up last time, it is never ever round burr. It is always lance drill. The problem with the round burr is that if you were to use it at the low RPM of a Physiodispenser, it tends to slide a lot. So there was a time when all textbooks used to say, let's start with the round burr. Now we always advocate never ever start with the round burr, because this is one instrument which we are not used to using routinely. We are used to using what? A rotor, high speeds, that doesn't actually slip as such. This tends to slip quite a bit. The main use of round burr which you will be doing in implantology now is, suppose the ridge is sharp and you want to flatten it out. That is where the round burr is used nowadays. Instead of the round burr, the first drill that you are supposed to use in your implant osteotomy is lance drill. Lance is another name for spear. So this drill, can you see a latch is here? This latch is like a micromotor burr, and in this handpiece we have a push button here. So this is like an erotor handpiece. So the method of attaching any osteotomy implant drill to a Physiodispenser handpiece basically is that we tend to rotate it till the time we get a sort of a catch, and while removal we have to pull it like this. So the point remains the same. While putting, no need to press the button, you just have to engage, and while removing you have to press the button. Is it fine? So what exactly is the purpose of this lance drill? The purpose of this lance drill is the dense cortical bone has to be perforated with this lance drill. Okay, so suppose I want to start osteotomy preparation in this area, or for that matter I want to start with osteotomy preparation in any patient in which a missing tooth is there. There are few things that I need to keep in mind with regard to angulation and placement of the implant. With regard to placement, I already covered 1, 2, 3 rule that will tell you where to place. With regard to angulation, the rule is simple: be it a natural tooth or be it an implant, forces are best borne if they are directed along the long axis of the implant or the tooth. So the rule is simple, that mesiodistal placement should be in the center. Mesiodistal angulation should be either straight or it should be parallel to the anterior tooth root, and buccolingual angulation should be such that the back of the handpiece should be falling roughly in the central fossa of the antagonist. I will repeat: mesiodistal positioning in the center. We are talking about single tooth implant placement. Mesiodistal angulation roughly parallel or straight or parallel to the anterior tooth. So it can be straight or slightly mesially tilted following the curve of SPI. And finally, buccolingual angulation. Buccolingual angulation should be such that the back of the handpiece is roughly falling in the central fossa of the antagonist. So if you were to do this sort of osteotomy, keeping the future tooth in mind, the longevity of the implant would be quite a bit. If you were to do an osteotomy like this, ultimately the forces won't be directed along the long axis of the implant, and if you were to do an osteotomy like this, again the chances of failure of the implant are quite a bit. So is it fine? The final osteotomy size should be, it should be slightly narrower than the diameter of the implant to be placed, and it should be slightly longer than the length of the implant to be placed. Why narrower? We had covered it in the earlier video, because we are anticipating some amount of bone loss because of trauma caused during osteotomy. And why longer? Because the implant has to be either equicrestal or slightly subcrestal, never supracrestal. So if you could just hold it once. So now the implant that we will be placing, these are the dummy implants that we have for this demonstration. And in these dummy implants, we will be placing this particular implant 4.5 into 11.5 millimeter. So in order to place an implant of 4.5, let's say round figure of 5 millimeter diameter, how much should be the distance? It should be 2 millimeter from the adjacent tooth plus 2.5 millimeter of the diameter of the implant. So now I had set it to 4. I'll just increase it to 4.5. It is already 4.5. Angulation we will be following, and this time always and always we have to feel the buccolingual width first, and then roughly in the center of the ridge we will be making a hole like this. So again the same procedure demonstrated again, in which what we have done, we have made an osteotomy. We have initiated an osteotomy in which the cortical bone has been perforated by the lance drill. Now in this the rule is simple. Please ensure that the drill is rotating before it is entering, and it is rotating till the time it is coming out. If you stop in between, what will happen is the drill might get stuck in the osteotomy site. Okay. So now once this is done, now we move on to the next drill. The next drill is what? It is the 2 millimeter twist drill, the first drill that we have to start. So always and always we have to start with the narrowest drill, and then we have to move on to the last drill, which should be roughly 0.5 millimeter or slightly lesser than the diameter of the implant to be placed. So now this 2 millimeter twist drill I am placing, and once I have placed this thing, I need to apply a stopper according to my 11.5 millimeter implant. So I'll be picking up the drill stopper of 11.5 millimeter, and now I am placing that 11.5 millimeter stopper in my drill. Now this 11.5 millimeter stopper means what? That the remaining drill which is outside this stopper is slightly over 11.5. The tip is not included. So if I were to go full length with this drill, my ultimate implant would be subcrestal only. Are you getting a point? Okay. So suppose I start with the osteotomy here. So I'll have to twist it like this. So now keeping it parallel, slight pumping motion. Why slight pumping motion? Because ultimately we want the irrigant to reach the base of the osteotomy. And now I don't need to count. Straight away what has happened is the drill stopper stopped at the desired depth. So this is the main advantage of using drill stopper. So the next thing would be, I remove the drill stopper from the drill. I start with the next drill. Next drill is 2.4. So 2.4 osteotomy, again the same thing. Now I attach the drill stopper. Once I attach the drill stopper, how much is the remaining length? Roughly little over 11.5. So once I have confirmed, now again I will be starting with the osteotomy, and we take it out. So did you notice this drill went a little bit more easily than the first drill? So please understand, only 2 millimeter, maximum 2.4 millimeter. These are the end cutting drills plus side cutting. The remaining drills are only side cutting drills. They only increase the diameter, they don't increase the depth. They sink in very easily. So again the same thing repeated. I'll just rush it up once. So the next drill is 2.8. All of you are getting this thing once. So once you have made the initial depth, since I told that the remaining drills are only and only side cutting, always and always verify the initial depth with 2 millimeter or 2.4. So for that you can use a depth gauge also. Many a times the depth gauge would be too wide to go into these initial osteotomy sites. The depth gauge is good enough once the osteotomy is fully prepared. But we have a very good periodontal instrument, the UNC 15 probe, the University of North Carolina periodontal probe. So this has markings at 5, 10 and 15. The black bands at 5, 10 and 15, otherwise markings at 1 millimeter intervals from 1 to 15. So straight away you can verify the depth with UNC 15. So again, this is one instrument which I would definitely recommend. Okay, always and always use UNC 15. So what you are seeing is at least the 10 mm mark is inside for your 11.5 millimeter implant. Plus, again I say the first rule of surgery is safety first. So what you are supposed to do is, you are supposed to ensure that it is not dipping inside. You are reaching rock bottom. That means you haven't caused any perforation or you haven't entered any vital structure as such. Okay. So now I have verified the depth, and now once I have verified, I can continue with my osteotomy. So the next drill which I had attached was 2.8. So always and always please remember, implant osteotomy preparation is not a race. So many people try to demonstrate. I placed an implant so fast, as if they had to catch a movie or a dinner after implant placement and the patient was also in a rush. No. The more atraumatically, delicately, gently you do it, the more would be the longevity of your implant. You, under no circumstances, you are supposed to increase the pressure and the speed and unnecessarily cause trauma to bone. So straight away again the next drill would be, take your time and let it go inside. And can you see, now with hardly any resistance it is going inside. All of you are able to see. Okay. So once this has been done, the next drill is 3.2. So 3.2 millimeter drill we are taking. So what is this thing called? This is known as sequential osteotomy preparation, and this is the primary funda of atraumatic osteotomy preparation. The rule is you are doing bone surgery, but with as little trauma to the bone as possible. Okay. So next drill is what? Now again this is 3.2, and straight away slight pumping motion also you can do, and you have taken it out. So 3.2 has been done. Now can you see the size of the osteotomy also increasing? Okay. The hole is comparatively wider. All of you are able to see. Now we move on to the next drill. This drill we can just focus upon. So we have covered till 3.2 right now, and we are moving on to the second last drill, that is 3.6, and after this it would be the last drill, which is 4.2, right, for a 4.5 millimeter implant. So now again so this is sequential atraumatic preparation, and now we move on to the last drill, that is 4.2. So why 4.2? Because I am planning to place a 4.5 millimeter implant. Okay. So now with 4.2 drill, I have attached the drill stopper again, and we are just finishing off the preparation with 4.2. So now my osteotomy is prepared. Slight water is there, but you are able to visualize as such. This is the osteotomy which has been prepared with ample distance from the adjacent tooth. So this osteotomy preparation is the key. The more you create it gently, atraumatically, more would be the survival of your implant. So now once it is done, we can just place the drill stopper back, and we can place this thing back. Okay. So now the next step is what? We need to place the implant. So we have the original implants also, but we won't be opening up this packet as such. Implant normally comes, I fix, in this sort of a packet, right? It basically comes as a implant which doesn't have a mount inside the packet, right? So we have to use our custom mount or the stock mount that we have in the kit as such. So this is the mount or the extended mount that we have to use for engaging the implant from the implant packet. Okay. So the rule is very simple. Implant is surgery first, prosthetics much later. So the rule of surgery is safety first. So never ever leave any instrument unattended in the patient's mouth. Otherwise the patient will end up swallowing that instrument. So the rule is always and always engage this extended mount into the torque ratchet first. So once you have engaged it into the torque ratchet, this is one thing which was demonstrated last time also. This is basically the beam type or the spring type of torque ratchet. Torque ratchet is the most expensive instrument in the implant kit, and the basic purpose is that we should be able to tighten it with a certain amount of force as such. Okay? As long as the arrow is pointing towards us, that means we are tightening the implant, inserting the implant, and suppose we were to rotate it and the arrow is pointing away from us, that means we are taking out the implant. So I'll demonstrate both. And what's the purpose of this pin then? This pin has these markings written here, 15, 20, 30, 35, etc. These are the torque markings. So you can measure the torque in between, that at what force are you tightening your implant in the osteotomy. The moment excessive torque is there, that basically means what? You are actually crushing the bone in the osteotomy, on the periphery of the osteotomy. So the chances of failure of the implant increase. That means somewhere your osteotomy was too narrow, you might have to widen it up. Suppose hardly any torque you are getting, that means you have over widened your osteotomy. Your implant might fail because primary stability won't be there. So better take out the implant and place a wider implant. If it is too tight, widen up the osteotomy. Okay? So now I'll be engaging this implant here. This is a dummy implant that we have, and then subsequently now we can please hold it once, start tightening the implant as such. Okay, so now what we do is we engage the implant and we support it with our supporting finger. So always and always in all surgeries, the supporting hand plays a major role. Learn how to retract with the supporting hand, learn how to support your instruments with the supporting hand. So now once we start tightening it, it is going easily. In between, what you can do is you can measure the torque with this pin. So the torque is quite less right now. Now you keep on tightening, give it time. Suppose it would have gotten stuck in between, that means the bone is too dense. You can try bone expansion, especially useful in the maxilla. So for bone expansion, what you have to do is you have to turn this arrow around. That arrow which was pointing towards us has been pointed away from us. So what does that mean? Now I am taking out the implant. So by rotating it in the reverse direction once or twice, I am expanding the bone, right? And then now I have turned it back towards me, and now I am rotating it again. So can you see? My implant is going inside. Now suppose at some juncture in the patient's mouth you were rotating, but the patient's adjacent teeth or the lip start interfering. What you can do is you can always remove this extended mount and use the longer mount also which is available. So this is the longer mount which is available in all the kits, and this we can just engage it once, and we have to engage it first. Right now it is not engaged, now it is engaged, hex to hex, and now we can start rotating it. So now can you see this distance has increased. So in the patient's mouth, otherwise the lip, teeth, etc. would have started hitting. Now you will be able to rotate it easily. So now take your time. Here I am just rushing it up, but in the patient's mouth you don't have to take it like a race. So now we are taking it inside, and this has to take its own sweet time. Okay, there is no rush for it because ultimately some amount of bone expansion is desirable at the time of implant placement. That is good for the longevity of the implant. So now what has been done is, let's say I placed it initially. Now I need to check whether I have gone till the exact length or not, whether the depth has been achieved or not. So that can be easily be checked whether my implant placement is correct or not with an explorer. So what we do is we move it on the adjacent bone and we try to move it like this. So suppose it is sinking like this, that means either it is equicrestal or it is subcrestal. Suppose, for example, here it is still supracrestal. Suppose it would have been supracrestal, the moment you move it, your instrument will get stuck there. So what does that mean? My implant is still above bone level. I need to take it inside. So how will I take it inside? Now I have checked, maybe half a turn or so more I have to give. So again I attach the extended mount, then I attach it in my implant, and now again what I do is I go a thread or so more inside. Slight subcrestal is what I am trying to do. So now this implant was already equi or subcrestal from the distal and the mesial side. Buccal side it was supracrestal. So again what I am supposed to do is check it again. So can you see? This time it is not getting stuck. So what does that mean? It is either equicrestal or it is subcrestal. So it is always better It is always better to check with this thing instrument. Now this implant here is hollow. What do you call this portion of the implant which is hollow? Crest module. This is where the abutment part would be going inside. But the point remains the same. Can I leave it hollow like this? The tissue will grow inside this thing. So I need to attach something known as cover screw. So this is the cover screw which comes in the iFix kit. It comes in all the implant kits. Okay, meaning there is a choice whether the implant is coming with the mount or not, but cover screw will be there always. Okay, so now we have to engage it with the hex driver. We have taken it out, and now we are supposed to place the cover screw in the crest module of the implant. Please remember, this cover screw will be getting tightened only and only in the same direction in which the implant has been placed. So once it is tightened as such, you give a slight reverse torque. Reverse torque is basically to prevent cold fusion, that is, it should not get stuck with the implant, and we tighten it as such. So this is the implant which has been placed with the help of hex driver. Hex driver placed the cover screw as such. Is it fine? So this was just a brief overview of hands-on of implant placement in artificial mandible. So we covered up the basic principles, the demonstration part. Few things vary according to the kit which we are using. So now we will be starting with the hands-on, in which all of you would be placing it in the mandible. We hope that by our small demonstration, few basic things we were able to make it clear. In the next video, we will try to make a live demonstration of implant placement in the patient as such. Please remember to subscribe and like our channel, which goes by my name as of now, Dr. Mayur Kaushik. Thanks a lot for watching. Have a nice day. Jai Hind.